Hey everyone, welcome. So if you're deep in prep for your final FRCA, you've definitely come to the right place. This is going to be your high-yield guide to paravertebral blocks. We're going to break down everything you absolutely need to know to nail this topic, all the way from the core principles to what the latest clinical evidence is telling us. Okay, so here's our roadmap. First, we'll cover what a paravertebral block actually is. Then we'll dive into the anatomy, which is absolutely crucial. From there, we'll get into the how-to, the indications and contraindications, the risks and evidence, and we'll finish up by looking at some of the newer alternatives that are on the scene. All right, Section 1, what is a paravertebral block? From 1905 to modern practice. So let's start at the beginning. What exactly is a paravertebral block, or PVB for short? You know, it might surprise you to learn this isn't some newfangled technique. It was actually first described way back in 1905. And it's been a go-to tool for managing both acute and chronic pain ever since. Okay, so here's the formal definition. It's a regional anesthesia technique where we inject local anesthetic into this wedge-shaped paravertebral space. But what does that really mean? Well, the key takeaway is that we're targeting a very specific spot, right next to the vertebral column. The whole idea is to bathe the spinal nerves with local anesthetic right as they're popping out of the intervertebral foramen. When you get it right, it gives you this incredibly powerful and targeted analgesia, usually on just one side. Okay, next up, the crucial anatomy. Let's really understand the thoracic paravertebral space. And I can't stress this enough. For your FRCA, getting this anatomy down cold is absolutely non-negotiable. I mean, a solid grasp of these structures is what separates a safe, effective lock from, well, a problem. And this image is just perfect for visualizing what we're talking about. This is the thoracic paravertebral space, the TPVS. If you look at the cross-section on the left, you can see exactly where the spinal nerve sits. But, and this is the important part, look how close it is to everything else. You've got the sympathetic chain right there, and critically, the pleura. That proximity is exactly why we have to be so precise, and why knowing this anatomy inside and out is so important. All right, here are the boundaries you just have to commit to memory for the exam. Seriously, flashcard this stuff. Anterolaterally, we've got the parietal pleura. Medially, it's the vertebra and the foramen. Superior and inferior, the heads of the ribs. But the one you absolutely must know, the star of the show, really, is the posterior boundary, the superior costotransverse ligament, or SCTL. Why? Because for the classic technique to work, your needle has to pop through this ligament. It's the gateway to the space. Okay, so we've got the anatomy down. Let's get practical. How do we actually do this block? We're going to break down the two main ways, the traditional landmark technique versus the modern ultrasound-guided approach. So the classic landmark technique, this one is all about feel. First, you mark your spot, about 2.5 to 3 centimeters lateral to the spinous process. Then you advance the needle straight down till you hit bone. That's your transverse process. From there, you walk off the top or bottom edge of that bone. And here's the crucial bit. You advance just a little further, maybe a centimeter and a half, feeling for a distinct pop. That's supposed to be you going through the SCTL. The big problem, of course, is that pop can be really subtle, really subjective, and sometimes you just don't feel it at all. And this is why ultrasound has been a total game changer for this block. Look at that image. There's no guesswork here. We can literally see everything. You've got the transverse process, that bright white line of the SCTL, and right below it, that shimmering line of the pleura. You can guide your needle in real time, and even better, you can actually watch the local anesthetic spread and confirm you're in the right spot. It's just a whole different world. So when you put them side by side, it's pretty clear, right? The landmark technique is blind and relies totally on feel, which leads to a higher failure rate. But with ultrasound, you have direct visualization. That means a lower failure rate, it works faster, and it's generally much more comfortable for the patient. Honestly, there's no question that ultrasound is the gold standard in modern practice. Okay, let's move on to another classic exam topic, indications and contraindications. In other words, when should we use a PVB? And just as important, when should we definitely not use one? This table is basically your high-yield summary right here. So what's it good for? Well, it's brilliant for post-op pain after unilateral surgeries. So think things like thoracic surgery, breast surgery, or renal surgery. It's also an absolute lifesaver for the pain from rib fractures. Now, on the other side of the coin, the contraindications. The absolute no-goes are pretty obvious, patient refusal or a true allergy. But what you really need to watch out for are the relative ones. Things like coagulopathy, sepsis, a bad spinal deformity, or a tumor in the area. Those are all major red flags that should make you think twice.
All right, every procedure has its risks, right? So let's dig into the evidence base. What do the numbers actually tell us about failure rates and complications? Again, this is a super important area you'll need to know for your exam.
We've all been there. You do a block and it just doesn't work as well as you'd hoped. But what does block failure actually look like when you break it down by the numbers for each technique? And wow, the numbers here really do speak for themselves. If you look at the landmark technique using loss of resistance, the failure rate is up around 5.2%. That's pretty significant. But when you switch to ultrasound guidance, that rate drops to less than 2.3%. The data is clear. Ultrasound is just way more reliable. Okay, but what about the scary stuff, the complications? Well, the main takeaway here is actually pretty reassuring. The incidence of major complications is low. I mean, things like hypotension, hitting a blood vessel, or even a pneumothorax, which is what everyone worries about remembering how close that pleura is, they all happen in less than 1% of cases. The most common issue you might see is a bit of epidural spread, but even that is only around 2%. So all in all, it's a relatively safe procedure. And for our final section, let's look at what's on the horizon. The PVB is a fantastic block, but the question is, can we get similar results with techniques that are maybe even safer? Let's explore some of these novel paraspinal alternatives. This diagram is great because it really shows the difference. See the PVB needle? It's going deep, right into that paravertebral space. But now look at the others, like the erector spinae plane block, or ESP. The needle placement is way more superficial. We're not trying to get into that deep space. We're just aiming for a fascial plane. And here's the ESP block on ultrasound. The really crucial difference here is the end point. Your needle tip lands right on bone, the transverse process. It's a hard stop and it's far away from the pleura. You inject your local into that fascial plane right on top of the bone and let it spread. And that's exactly why these newer blocks are so promising. They're arguably easier to learn and perform, and they have this fantastic built-in safety feature. And that really leads us to the big question for the future, doesn't it? As these newer, arguably safer, and easier blocks become more and more widespread, how is that going to change the role of the classic PVB in our day-to-day practice? The paravertebral block is a powerful, time-tested tool, but the future of truncal analgesia might just lie in these simpler, safer alternatives. It's definitely something to think about. So that wraps up our high-yield review of paravertebral blocks, and all of this was based on the fantastic article from BJ Education published in 2020. I really hope this was helpful for your revision. Thanks so much for joining me, and best of luck with that exam.